again. I hate to see this as it is at this very moment, because I wish we didn't have to be here. I wish we could just be floating off into the sunset, not doing anything. That was probably the sound of my Dr. Pepper opening up. And I'm gonna need Dr. Pepper for this. Anyone listening, maybe you should grab a Dr. Pepper for yourself. We got 3 chunky things to go through today, including, and actually not limited to, pancreatitis, cirrhosis, and hepatitis. So, anyway, we're starting with the pancreas and that pancreatitis, but at the end of the day, this is like a brief overview / review of biliary conditions and, like, the whole, like, psych system, what the frick? Physiological system of bile and other cool, fun things. So, anyway, yeah, what does the biliary system do? How? Well, so, allegedly, okay, and it's only because it's in the name, the biliary system functions to create and store bile. Now, what does the bile producing? Well, it's this liver thing here. The liver thing, let me actually check this, because it'd be so awkward if I was wrong. Actually. I'm bringing the mic closer because then I can type on my computer, which sounds, silly, but what produces bile? I'm just going to say the liver. Ugh, so freaking smart. But yeah, anyway, this guy, the liver, produces bile. Now, what does bile do? Well, according to this PowerPoint slide here, bile helps to digest fat, okay? Which is kind of important, especially because your average diet, now, not a diet of Dr. Pepper, because this bad boy has 0 grams of fat. I would know because I'm looking at it right now. But a lot of your diet has fat in it, especially these days. And so to be able to actually break that down so that it doesn't go up and get your GI system all angry and cloggy and not happy here, that's probably a really good thing. Now you'll notice this really small, really demure little duct here, okay? So we have the gallbladder here, whose function is to hold on to the bile. Those stones aren't relevant, okay? Don't look at them. Pretend that's bile, okay? This is this really cute little bile here, and it's gonna travel down here into the biliary cystic duct, okay? That bile is gonna travel down there, and the pancreatic duct, okay, whatever, they call it a lot of different things, okay? And it's gonna go down here into what they call the common bile duct, okay? Now, the pancreas is this really cute little organ here that produces pancreatic enzymes. Okay, now we're getting into the weeds, okay? But just you have to stick with me here. The pancreas produces lipase, protease, probably spelled that wrong, and amylase, which are cool, okay? The reasons that those are important, okay, is that they are the 3 things that we get our nutrients from: proteins, which is protease, lipids, which are fats, and amylase, which are carbohydrates. Now, why do we need these, though? Because, what do you think? Do you think that food just gets into our stomach and then just, like, travels like it's on a freaking road trip down to the rectum and just magically becomes poop? I don't think so, buddy. What really happens is that in this process of digestion, the food gets here and is broken down by our stomach acid, and that's where the road trip begins, okay? Once it hits here, though, to the duodenum, whatever, okay? I'm not a hater. It's going to head down in here, and it's going to be inundated. Can I learn how to speak? It's going to be inundated with all of these compounds. Now, they all end with ace, which means they break stuff down. Yeah, I'm kind of a chemist. Probably heard me swallow there. Well, these guys break down the components in your food so that our body can actually, like, use them and stuff. Now, the question that I'm thinking right now is, why do we need bile? when I have lipase? Wow, that's a great question. So here's our AI overview. Thanks, Google. When lipase is the enzyme that breaks down fats. Okay? And fats are, by the way, everyone thinks like fats are the enemy, but here's the deal, okay? If I was living out in the wild, you know what I'd want to get a lot of my calories from? Fats. Because I think fats have like 9 9. Ugh. Dude, I'm on like a roll right now. 9 calories, okay? That's a big chunk, okay? Why am I saying that? Fat's not bad, but let's go back to here, okay? Lipase breaks down fats so that we can actually like use them. But bile emulsifies large fat droplets into smaller ones, increasing the surface area available for lipase to act on, allowing for better fat digestion. So because of, I don't know, I mean, have you ever looked at those chains of fats? Triglycerides. Yeah, those are big. It's pretty rad, actually. So these bigger fat droplets, these really long, chunky bits of fat, are kind of cut up into smaller chunks of fat, making it easier for the lipase to work. So if we didn't have bile, our lipase would be fighting an uphill battle to defeat the Goliath that is the fat in our diet. It would be David versus Goliath, except that this time, David doesn't have his sling. Wow, that metaphor was so good, I'm gonna forget it. So even if you have lipase, large fat droplets would remain largely undigested if they wouldn't have enough surface area to work on, leading to poor fat absorption and potential nutritional deficiencies. Of course, because it's not actually being absorbed. It's just gonna come out, it's actually gonna go on the food road trip that we were talking about, where it just gets excreted, gets broken down, but it doesn't get used. So it goes on the road trip, and it can't even make a scrapbook from that road trip, which is really sad and tragic, okay? So we talked about the functions of pancreatic enzymes and like kind of went over this pathophys a little tiny bit, okay? Gallbladder stores bile. There's really nothing else that it does, which I say, and then I'm going to look it up. Does the pancreas? No. Does the gallbladder do anything else other than store bile? It concentrates bile, okay, but at the end of the day, all it's doing is loading bigger shells into the gun shell shooter. Yeah, I'm kind of a soldier. Don't quote me on that, actually. I'm not, I promise. I'm just a yapper. But anyway, so that's the pathophys, okay? Liver makes bile. Bile goes into the gallbladder. It gets concentrated and stored. Oh no, now we got all this fat in here, and our lipase is being excreted from the pancreas through the common bile duct into the duodenum. And it says, hey, there's a lot of fats here. I need you to emulsify these fats for me because I don't have enough surface area to get it all up in there and get our nutrients. And the gallbladder says, no problem, cousin. And so it sends out its bile, and through that same common duct right here, okay? It sends it out through this exact same duct, which we'll talk about how this duct gets absolutely abused in a couple of slides, I think. And it'll come out here, emulsify the big, chunky, large fat particles so that our lipase can properly digest it, and boom, everything flows really well and perfectly, and we are happy, healthy, and we don't have some sort of blockage here, and our pancreas isn't auto-digesting itself. Wow. Well, what could possibly go wrong in this perfect system where there is one area, one common area where, if something was to be blocked, that entire process would be affronted. If you didn't catch it, this is definitely foreshadowing a common literary trait. How did this get here? Cholecystitis or cholelithiasis? Well, all right. I don't know why okay, it says that I'm pretty sure that those are the same things. What is cholecystitis? Inflammation. Well, that actually totally makes sense. So cholecystitis can happen because of a lot of things. It's usually like stones, but it could just be, I don't know, you could have gotten hit in the gallbladder. Here we have Google saying trauma. Hey, when I think of trauma, I think of a boxing match. Brother just got punched in the gallbladder. Hey, I'm not going to sit here and say that's not a thing that could happen. Tumors, of course. Infections, probably. But it's less common. Stones. Stones are going to be your more likely cause for... Well, I don't actually know what's going on in that picture. That looks like an angry gallbladder, but it could also not be an angry gallbladder. Yeah, it could be a stone. It looks more like a gallbladder. I'm not a doctor, okay? I never said I was a doctor. So, I'm glad they have this picture there, though. It's really cool. I had to take a quick DP break. Now, in cholecystitis, which is just the inflammation of the gallbladder, or cholelithiasis, which is just stones, which stones are kind of cool. I remember we went over stones like a little bit in at least one of the classes I've taken here in my 3 years. Yes, I am a senior. Yes, I'm about to graduate. Those stones just happen because the bile just sits around. Hold the freaking phone. Why do you get, not kidney, gallstones. There it is. Cholesterol imbalance. Cholesterol. No, cholesterol. Ugh. Dang it. So when the bile produced by the liver contains too much cholesterol, it can crystallize and form stones. Other factors could be low levels of bile salts that help to dissolve cholesterol. Or, oh, now this is interesting. This is also foreshadowing high levels of bilirubin. Oh my word. This is so spooky and scary because we're about to talk about the liver next. But that's not the problem, okay? Gallstones, cholesterol, bilirubin moment, okay? But anyway, at the end of the day, all right, what does this mean? Okay, you got this blockage. You have this blockage or whatever, okay? So the bile is just stuck in there, sitting around, being like, so what am I going to do? Just sit here? And, of course, the stones or the inflammation irritates the wall. I mean, I'd be irritated if I had a rock in me. Just saying. Leading to edema. That's swelling. That's the smart word for swelling. Everyone knows that, except for, sometimes. Can lead to necrosis and gallbladder rupture or gangrene. I mean, hey, if you let something, because that's the thing, if there's a stone in there and it's blocked, that's causing irritation. It's causing all this buildup of angry and pressure. It's probably likely that the liver is not going to just stop producing bile. Like, it knows you probably need bile. In fact, it wouldn't surprise me if, because there's not bile going out, right? Let's say that the blockage happened kind of close up to the end of the tube. The body's probably like, hey, where's our bile at, bro? And the liver's like, I don't know. I just sent like a massive shipment down to the gallbladder. I don't know what's going on. And the gallbladder's about to explode because it's so full of crap. Hold on. Why do gallbladders... I'm not seeing explode. Bladders explode. Okay. Due to inflammation, a ruptured gallbladder can lead to sepsis. No! So gallstones block the tube, causing bile to build up and inflame it. Okay, right. Okay, you can also have a parasitic worm infection. Right. But I want to know how it happens. Like, how? Block the cystic duct, prevents bile from flowing out of the gallbladder. Okay, well, it doesn't talk about it. I'm going to assume it just can't handle anymore. It just simply cannot handle it and the ruptures burst. Okay? That doesn't sound fun to me. Alright? Boom. Not cool. And now we're getting here to obstructive jaundice. You know what? Now I'm looking at this and I'm like, what the frick? I'm like, where... because, okay, what is jaundice, first of all? It seems like we went from here, which is gallstones can happen and then blow up the gallbladder. Oh, no, not the gallbladder. Now I'm in sepsis. And now we're going into jaundice and icterus. Now, you'd think that jaundice has to do with, like, the liver, because what is jaundice? Why do we get jaundice? Jaundice happens when there is an excess of bilirubin that we can't really get rid of, or the mechanisms that we have for breaking it down aren't really working. So I love this picture where they have two guys just sitting next to each other. This guy is normal, allegedly. So if an alien watches this guy that's what a human looks like. Normally, that's what that guy's skin looks like. And then this guy looks like he's been put under like one of those photo booth like lenses where everything's a different color. Yeah, and it is a yellowing of the skin. I would say that that's not cool. It's not good, all right? That's jaundice. Icterus is just when that happens in the eyes. The sclera of the eyes, for any nerds out there, I say, as I pulled sclera out of my butt cheeks. All right, first of all, can I get jaundice again from gallbladder? Okay, so how about this? You'll never believe this. You can get jaundice from gallbladder issues like gallstones or inflammation, which is cholecystitis and cholelithiasis. Litho, by the way, means stone, for any mega nerds out there. Okay. Jaundice is a condition that causes the skin and whites of the eyes to appear yellow. Okay, well, that's icterus. Guys, I'm sorry. My nerd is showing. I'm sorry. I'm going to stop. So here's how it happens. According to the AI overview, my entire presentation is AI generated. A gallstone can block the bile duct, preventing bile from flowing into the intestine. This causes the body to absorb the bile's yellow pigments, resulting in jaundice. Well, now here we have something very interesting. So you could say, this obstructive jaundice, is this caused, okay? Is obstructive jaundice caused by cholecystitis? Okay, just I have to take a minute to spell here. Caused by hyperbilirubinemia. This might be too smart for AI overview. No, it's not. It is indeed. Look at this. They are so cute. Yes, obstructive jaundice is indeed caused by hyperbilirubinemia, as the inflammation in the gallbladder can obstruct the bile duct, leading to a buildup of bilirubin. Okay. Causing bilirubin to accumulate. Okay, but why? Why? Okay, well, first of all, why do we get hyperbilirubinemia? And then we're gonna, if our bile duct is blocked. Okay. It prevents bile from transporting bilirubin out of the liver. I almost said a river. Now we start to see the puzzles finally start to fall into place. I feel like freaking Sherlock Holmes right now. Well. That first AI overview was totally wrong, by the way. I want to just put that out there. That was totally... I'm not going to say it was wrong, but I would say it was misleading. Because it's not the bile that causes the jaundice, and it never was. AI overview, Google Gemini. You should be ashamed of yourself for spreading misinformation to hopeful scholars like me. Bruh. Anyway, it's simply because bilirubin is transported out of the liver via that same bile duct. That same duct. This one right here. Look at this. Now, do I know which one of these that is? No, I do not. Did I probably learn what those ducts' names were back in AMP 1 or 2? Probably I did. And have I forgotten them? You betcha. So here's the thing though, right? Whichever one of these that comes out of, okay, it goes here. And so people, this is really important, bilirubin that's kind of produced here as a nasty, disgusting trash bit residue from our red blood cell death, okay, is put into the duodenum, the beginnings of our small intestine, to eventually travel, to take the road trip out of the body. Okay? We dump that waste product in here, in the small intestine, to be transported out of the large intestine. So how do we get rid of our bilirubin, you might be wondering? By pooping, people. By pooping. Why is that going to be important? I don't know. I actually do know, okay? And I'm hitting you with that foreshadowing again. I bet you're on the edge of your seat right now. Anyways, so once this is blocked, though, that bilirubin is just sitting here, goofing off, being like, maybe even chilling out in here, and the liver's like, hey, buddy, can you actually, like, open that freaking duct up again? And it's sitting here like, I don't know, man, the cholesterol stones, they're too strong, they're too powerful. And so then that bilirubin goes outside of those whatevers into the blood vessels. Listen, okay, whenever something doesn't like being where it's at in the organs, and okay, FYI, the liver is a super vascular organ because it's like one of the filters in our body. All like a ton of stuff. There's like, I don't even remember what it's called. Mesenteric whatever? No, not that. I mean, the inferior vena cava is like right here. Okay? And there's a lot of different stuff that is there to be part of the vascular system of the liver. So it's not that hard for the bilirubin to be like, well, fine, if you don't want to get rid of me, I'm staying here forever. And go into the blood system, the circulating blood vessels, and now you're yellow. And I don't mean that in any sort of derogatory way. You are literally this color, brother. You're literally this color because the bilirubin is sitting here pigmenting your skin. Now, this doesn't happen overnight. I think if it did, you're probably going to die. No, listen, I don't know that. I'm just a goober. I'm sure something like that has happened. But, like, that's not normal. Like, usually if you do get some sort of jaundice, it'll be a slow process of, oh no, I've got this problem and I haven't had it fixed for kind of a while. So anyway, that's the problem that cholelithiasis causes, is that now there's this occlusion, you could even say, in this duct, and not only can we not move the bile out, which is now just causing this accumulation of bile here and making it so that we can't digest fats appropriately because our lipase is working as David without his sling. Wow, I'm so funny with that one. But now we also can't get out our bilirubin, and high bilirubin levels can cause brain damage. But you know, it is more than anything an indication of like, okay, something is like really wrong here. We need to fix whatever is blocking our bilirubin from being able to be excreted. Because with that bilirubin buildup, there's a lot of other things that the liver wants to throw out into the trash chute that is our butt, okay? Including ammonia. Ammonia? Yeah, and we'll get to that actually. But let's continue going down here. Non-surgical management. Ooh. Sorry to take another DP swig. Yeah. Oh, I hear the haters out here. Oh, I do. You think I'm not listening, haters? I know you're saying that I traded in one stone for another by drinking my Dr. Pepper. Okay? I know that. And you know what I have to say to you? I'm still drinking water, bozo. I'm just kidding. Please. I'm just being silly. Being very, very silly. I am drinking water right now. All right. Non-surgical management. Because it is possible to rock concert away our gallbladder stones if you catch it early enough. So, of course, included with this non-surgical management is pain control, because it is not comfortable. This hurts so bad. It's going to be right upper quadrant pain. Yikes. Oh boy, this does not feel good. So, they'll give you morphine or Dilaudid to help with the pain. And help with the suffering. Now, there's one thing that she said we won't give. Now, do I remember what that is? Hey. No, I don't. Let me look, though, in my history, because I know she brought it up, and I am, like, pretty sure. I'm pretty dang sure that it's gonna come up again. I'm, like, Mepridine, also called Demerol. Because apparently, so our teacher is kind of old. And that's not a bad thing. She's very wise, okay? But back in the day, they used to give, like, Mepridine, in parentheses, Demerol, for this. And there's been some studies that have shown that it can cause spasms in the sphincter of Oddi, which is just this thing right here, I think. And that's not good because that just causes more pain and more problems. So, not good. Anyway, so Mepridine or Demerol is a no-no when it comes to, at least for the testing purposes. Like, if I saw a physician prescribe this, I'd probably be like, I might ask if I had the opportunity to be like, so I know this can cause, like, spasming. Are we just gonna, like, do you still want to give it? Or, is this a risk versus reward thing? Because if they're allergic to a bunch of other stuff, like, maybe I could see the reason for that. At the same time, it's something to know just in case. Because it's always, I would rather be safe than sorry. So, Mepridine / Demerol is a no. But morphine and Dilaudid are cool. They're rocking. Okay? Another thing we can do that anticholinergics, because they reduce spasms. And it's really the spasms of that area that they cause pain, and they also make the actual issue worse just by increasing that irritation. They have this one right here, dicyclamide, in parentheses, bentyl, that can, and because remember, cholinergics, like, move things. Anticholinergics don't move things. What? And I know it goes down to, like, the different secretions and whatever, okay? I'm simple. I'm a simple girl. I'm not a smarty pants. I'm a simple girl. Dicyclamide, we're going to reduce the spasms, reducing the movement, okay? Simple, easy breezy, bentyl. That's crazy. Antiemetics. Okay, because, throwing up, this is GI related. Anytime you have some sort of GI problem, your body's just like, okay, here's a good idea. How about we just get rid of everything? How about we purge our way out of this problem? Well, so crazy thing, that only causes a lot of discomfort, and sometimes it can help to ease the suffering only by increasing the suffering in the short term. So antiemetics, especially if they're in the hospital setting, for the patient comfort, and a lot of other reasons, nobody wants to be throwing up all dang day. Promethazine, Phenergan. Yeah. Because it's not like them vomiting is actually going to get this stone out. It's just their GI system being like, hey, brother, we got one thing we can do right now, okay? We can have it either come out of the butt or out of the mouth. And the esophagus is like, hey, buddy, I don't make the decision here. Bam! Gut rest. Yeah, they don't need because this right here, the pancreas is stimulated to release the enzymes when the stomach does its thing or whatever. I don't know. Okay, let me check that because I don't want to freaking spread more misinformation like I will do with Google Gemini. When is the pancreas going to secrete enzymes? When food enters the stomach. Psh, buddy, I'm like 4 for 4 right now. Because of course, cholecystokinin, also known as CCK. Hey, kind of on it today, babes. But anyway, that's all part of this same duct right here. And so, listen, depending on where the stone is at, it could be up here, it could be up here. Food is not going to be good right now. It's probably going to irritate this and this and this. Maybe this, I don't know. It's not going to be good. And by the way, also they're throwing up. They're throwing up. Not cool. And I would say maybe they can drink water, but I'm not a doctor, though. So they'll be the ones making those decisions. But at the end of the day, these are the things that, as a hospital, this person will be doing. Avoiding fatty and spicy foods. Well, spicy foods just hurt your body. they're not really, I mean, it's just an experience. It's an experience of hurting yourself. But fatty foods especially here, because remember, guys, when does our gallbladder say let's reduce bile? When we've had a fatty meal. And it's the lipase is like, oh no, I'm gonna need more help. And then our bile, trickles down, okay? We don't need fatty foods. Not right now. Our gallbladder is not actually able to work very well. And then remember, this is non-surgical. Lithotripsy. Remember how we said litho is like stone? Well, tripsy is to like break them up. To break up the stones. Break up the deals, okay? So using sound waves. That's why I said it was the rock concert. Oh, that's so funny. Oh, that's so funny. My knee just exploded because I hit it so hard. I'm sorry. I actually have to sit in shame after making that joke. I have to sit in shame. Anyway, by sending these really extreme waves towards the rock, they break it up into little pieces, allowing it to travel through this tiny little cute Demir duct. Whee! And then eventually get pooped out, just like the rest of the junk, okay? And then, yay, problem solved. However, if that doesn't work, they have to go in there and take out the gallbladder. Yeah, cholecystectomy. That sucks, actually. I know a lot of good people who have suffered from a cholecystectomy. They're alive. They were 100%. They're chilling. It's a lot like the gallbladder does more than the appendix, right? Let's just say it like as it is, okay? I'm sorry, appendix lovers, buddy. What is he doing for you? What is he doing for you? Nothing anymore for me, buddy. I got that bad boy out early. Whatever. Your liver, remember, is the thing that actually makes bile. So getting your gallbladder out doesn't do anything for your bile production. But the reason having a gallbladder is a nice thing is because big fatty meals. Let's say you ate a pound of French fries. Allegedly, okay, you were in a math problem. I'm not judging. Okay, but you eat this pound of French fries, and the French fries is in here, and your body's like, whoa, we need a lot of bile. Normally, the gallbladder's like, don't worry, cousin, I got you. And it spills out its bile, and it attacks the pound of French fries. Well, now this man doesn't exist anymore. So all we have is the constant trickle of bile. It doesn't really go up, right? Unless, I don't know, you train it to. But we don't want a ton of, there's just this trickle. It's just a trickle of bile. So with that pound of French fries, now, you only have so much bile. And if you happen to have more bile than fats, that's like, let's say, allegedly, how many stones did David pick up or whatever? 3 or something like that. 7. I don't freaking know. It's been a while since I've, gone through the minutia of this story. But he's only got 1 stone, so he's got 1 shot at taking out the fat. Otherwise, you took out a little bit, but the lipase can't break down everything, so you're not getting the nutrition that the pound of french fries would have given you. Unfortunately. I know, really tragic. It's not going to feel good. It might actually hurt, because you got a bunch of gunk that really can't be broken down. But, yeah, anyway, you'll still, okay, anyway, and they have animations and, laparoscopic procedures, which I don't really want to watch right now, because it's just whatever. Okay, so, post-procedure of getting your gallbladder out, because, right, see how that gallbladder is removed in this cute little picture? Yeah, that's what happens in real life. Hey guys, did you know in a cholecystectomy they take out your gallbladder? Yeah, it's gone. Okay. They put in a T-tube. What is a T-tube, I wonder? So, okay, this right here, this green thing is this, okay? And it just so happens that this doesn't exist anymore. Let's pretend that doesn't exist. All right? So a T-tube allows for, because your body is still used to having this gallbladder here, okay, where it can just sort of dump all the extra bile if need be. Well, in a cholecystectomy, that doesn't exist anymore. So your body almost has to, it's gotten used to just dumping its bile in a place, and now it doesn't have a place to do that anymore. So a T-tube is a temporary way for clinicians to make sure that the patient can get used to this new life of no longer having a gallbladder, okay? The bile, or the T-tube, holds the duct open, so that if we've got a lot of nausea flowing in, it's used to going here, and now no longer is doing that, because bile is a demand thing. You make more bile when you need more bile, or over time as you make more bile, because your gallbladder, yeah, at least that's how I understand it. Am I explaining it well? No. However, right, at this moment, you've just gotten your gallbladder out, and your body is still figuring out, so there's nothing that we can do right now. We can't put it anywhere. So you might have way too, much bile coming out, and there's nowhere for it to go, okay? Now you might be wondering, well, is that a bad thing? Why, what's the problem with that? Okay. Why are T-tubes important? Cholecystectomy, if I can spell. It allows for controlled drainage, providing a way to decompress the biliary system and prevent bile leakage while the surgical site heals. Also enables post-operative imaging. That makes sense. And we don't want bile leaks. Okay. What? What are bile leaks? Occurs when bile leaks from the bile ducts into the abdominal cavity. Oh, that's terrible. Oh no. And bile is a digestive fluid produced by the liver and stored in the gallbladder. Causes severe abdominal pain, nausea, vomiting, fever, jaundice, and chills. Yikes. Can cause inflammation and infection. Also can cause problems in the digestive area. So why this heals, we would rather just that extra bile flow out. And that T-tube really does just collect it in a bag outside. Because we don't want a bunch of bile if there happens to be a problem being all up in the abdominal cavity. That sounds terrible. So it is a drain. an outside drain, so you have to make sure it's hanging below the waist level so that gravity goes down instead of being like, oops, now we got bile flowing back in. That doesn't sound like a good idea. Now, this is pretty temporary because this is likely going to heal relatively quickly. But your patient is still recovering from a GI procedure, okay? And the point, right? Draining the bile away from the intestine can relieve nausea. Sure, let me write. Why though? Because otherwise, why does draining the bile away from intestine with T-tube help relieve nausea? And a bile duct is blocked, blah, 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 causing pressure. So I guess if there's a bunch of bile buildup, because the bile's like, well, where the freak do we go? We're not used to just trickling down here. The pressure and discomfort causes the nausea, because your GI system is like, what do you mean there's a problem? Quick, nausea alert! Quick, send out the nausea! And so it just makes you nauseous, which is not fun and cool. And that means, long-term, nausea could also have some cause nutritional issues. So by having that T-tube there, we're able to relieve that pressure, reducing the nausea symptoms. Well, that's so nice. If you hear anything, it's because I'm messing with this sticker that's on the stand for my microphone. Okay? Yes, that's exactly what's going on. All right. Anyway, enough of this gay banter here. The T-tube is clamped for 30 minutes before a meal. Okay? Right? Do you clamp T-tube before? Okay. Before and after. Clamped before. Perfect. I'm glad I wrote that down. I like to write stuff down that they say in class, and if I heard it wrong, I would be so screwed on the test. So clamp it 30 minutes before a meal. They have here T-tube nursing care NCLEX review is clamped for 1 hour before and after meals. Both sound good. I think it just depends on how much that patient needs. Like, you are going to be clamping it for shorter and shorter amounts of time because this patient's not going to have that T-tube forever. Like, eventually they're just going to be closed up and this trickle will just sort of work. The longer the tube can be clamped without nausea, the closer the patient is to getting the T-tube removed. So, like, while they're still rocking in the hospital, right, like, closer to when they actually got their gallbladder out, 30 minutes is probably a better estimate. But they have here an hour, and that's probably, like, a pretty typical, like, you'll start at an hour, you'll get to 30 minutes, and then, soon enough you'll get to, because you'll be trickling at a good rate, things will be closed up, your nausea will be kind of going away because things are flowing better, etc., etc. Yay! Woo! Okay, so that's just T-tube. That's getting your gallbladder removed. We talked about the non-surgical management. Now we're moving on to pancreatitis. Because we just talked about the gallbladder, which is just this cute little guy. He's always green and cute and all that cool little... Look at this little lima bean here. But the pancreas is, I would say, often forgotten. This cute little guy. He hangs out behind the stomach, behind the liver, which are big players. I mean, I bet if you ask a kid, like, about organs, name as many organs as you know, they're going to say stomach. They're not going to say pancreas. I wouldn't be saying pancreas. But me, I'm not a savant of the human body. So let's say it how it is, okay? Pancreatitis. Now, we talked about the pancreas and, like, what it does when we were looking at that cute little diagram. The pancreas is a organ that produces amylase, lipase, and protease, which are the things that digest food, okay? And every teacher that's talked about the pancreas will always bring up the question, well, if our bodies are made up of proteins, why is it that the pancreas doesn't digest itself? Wow, what an A+ question. that I just posed to myself that I, of course, know the answer to because I have been learning this for the past 3 years. There's this cool, thing that those enzymes are only activated after they, leave the pancreas. They're meant to activate, the pancreas shoots them out, and they activate upon essentially reaching the duodenum, and then they're like, okay, let's digest things. Let's go, come on. I think back in A&P, I totally learned the whole process for all of that. Now it's just a memory, a faded memory of a bygone and much more happy age. But let's not talk about that. That's nobody's problem except my own, okay? The main too long didn't listen for the past, 30 minutes is that everything that the pancreas is going to make, and then at the same time the gallbladder is going to release, goes through the common bile duct. And I love how they call it the common bile duct when there's pancreatic enzymes that go through it, but whatever. And there's our sphincter of Oddi. So I was obviously spreading misinformation when I said it was up here. It's down here. The sphincter of Oddi is just what pops the stuff from the common bile duct out into the duodenum, whatever, okay? The pancreas, okay? Look at this. They got 3 random little bullet points here. It's an endocrine gland. Ooh. Learn role with insulin and diabetes mellitus. Okay, what is the pancreas's role with insulin? Because I think it does have something to do with it's a hormone. Because it's an endocrine. Duh. Well, hey, now we know, buddy. The pancreas's primary role regarding insulin is to produce and release the hormone into the bloodstream in response to rising blood sugar levels. Ooh, yay. The pancreas, now this is mind blowing, people. The pancreas produces and releases insulin. This right here blew my mind, blasted my body into a whole nother state of understanding. Okay? So the pancreas is an endocrine gland. So it produces hormones like insulin. And what's the people in diabetes mellitus problem? Well, don't they have freaking islets? Are they Langerham? I don't freaking know. If they're Langerham, I'm so freaking cooked. Hold on. What in the pancreas produces insulin? I'm so freaking smart. It is the beta cells and the islets of Langerham. No, I'm not smart. The problem is I'm becoming indoctrinated into the cult of knowing about the human body. Islets of Langerhans? Are we serious? Anyway, discovered by the pathologist Paul Langerhan. I don't know. Listen, should I be impressed? Yeah. Should I also be really depressed? Yes. Yes, I am. I am. You can't stop me from being depressed about being like, isn't that the islets of Langerhans? I'm a freaking nerd, dude. What the heck? Anyway, endocrine gland. So the problem with diabetes mellitus 1 is that in diabetes mellitus 1, the Langerhans they don't work very well. Yeah, beta cell problem. They don't produce a lot of insulin. Bro. Hey, we got that. We knew it. We just didn't know it. And we had to have Google tell us that we remembered it. What the heck? Anyway, the pancreas is an endocrine gland. Produces insulin, blood sugar levels. Wow. And it's not like your blood sugar is kind of important. It's not like, having an issue where your blood sugar is super high can cause you to go into metabolic acidosis. Don't worry about that. And it's also an exocrine gland. Wow. Which means it's excreting digestive enzymes. Because what's the difference between endocrine and exocrine? Endocrine secreting hormones into the bloodstream. Exocrine secreting stuff into other stuff. I don't want to ask the thing, although I will, because I just like I like to see the circle. I don't want to have holes in my circle. Difference between, and look at that, it literally already knew. I should be terrified about that. Directly into the bloodstream, and then exocrine is through ducts onto the body's surfaces. Which, hey, let's get into the minutia of this. Technically, this GI system is a surface because it's open to the outside. Think about that for a second. Oh, we got sphincters and stuff, but like, hey, that's open to the outside. I don't care what anyone says. That's 100% open to the outside. Yeah, look at that. So, yeah, buddy. Endocrine and exocrine. Wow. I'm so glad we've had this chat. And then, of course, early activation of enzymes causes autodigestion of pancreas tissue. What does that mean? So, that whole conversation we had about, oh, well, why doesn't the pancreas digest itself? Okay. How about I... So, the digestive enzymes are produced in an inactive form. They only become active when they reach the small intestine, okay? Preventing them from digesting the pancreatic tissue itself. This protective mechanism is called zymogen activation. That's not important for the test, but it's cool to know, okay? What happens when these mechanisms fail? If something disrupts the normal process, like a blockage in the pancreatic duct, the digestive enzymes can become activated within the pancreas itself, leading to a condition called pancreatitis. Well. Looks like my foreshadowing has finally come to an end. Let's say that this cute little gallbladder thing had a stone, and that stone maybe traveled right here and blocked the freaking common bile duct. Hey, it happens, brother, right? And so now we've got all these enzymes. By the way, the enzymes are like, I don't know, 3-year-olds at the start of a race, okay? They are desperate to start running, okay? You can tell them to stop, all right? And that's usually what happens. The pancreas is like, stop. They're traveling. They hit the small intestine. It's like, go! Bam! They're running. They're running like a mad woman. Ah! Okay? But if you keep on saying stop, eventually those 3-year-olds are going to start to get restless. Okay? They're starting to get jittery. And then pretty soon, pancreatitis. Yeah, I said it. I went there, okay? And then here they say they have an ERCP, which is a student presentation, and it's like 22 minutes long. It was so long in class. Oh, it was so long. I was sitting here, I'm like, yeah. And look, I have a little note here. Watch video because it might be on the test. And you better believe I know it's going to be on the test. We have a quiz on Wednesday. It's going to be on there. We will come back to it. Okay? We're going to come back to it. I just need to finish this PowerPoint. Okay? But at the end of the day, we're going to talk about what is an ERCP. ERCP is an endoscopic retrograde cholangiopancreatography. Oh yeah, I did that first try. That's not edited. I'm kind of like Michelangelo, but with words. Don't quote me on that. Don't do it because it's not funny. It's not even correct. Endoscope. It's right there. Wow, it's like my computer can hear me because I'm speaking into a microphone. It's a medical procedure that combines endoscopy and an endoscopy. Didn't get that one right. And it's half the size, and x-rays to diagnose and treat problems in the bile ducts, cholangio, and pancreatic duct. okay, to diagnose conditions like gallstones, bile duct stones, pancreatitis, tumors, remove gallstones, place stents to open up narrowed or black ducts, and or obtain tissue samples for biopsy, especially for those tumors. All right, a thin lighted tube, an endoscope, is inserted through the mouth into the stomach and the duodenum, first part of the small intestine. A special dye is injected into the bile and pancreatic ducts, and X-rays are taken. Okay, cool. So we got a bang for our buck. We get to see in there. We get to mess around in there. We get to take stuff out of there. There's all this procedure can do a bunch of crap. Okay. So, based on the findings, the doctor may perform interventions such as removal of gallstones, using a basket or forceps, placement of a stent to open up a blocked duct, injection of medication to treat pancreatitis. Wow. So, it's usually considered a safe procedure, but our potential risks are infection, if there's goobers in there, bleeding, because this is an invasive procedure, could be bleeding anywhere where this tube can go into, okay? Which is not that fun, because we don't want to have internal GI bleeding because this has been raw, rubbing, whatever. Pancreatitis, because you are messing around, especially if you are messing around in there, you could cause a whole other problem. Damage to the bile or pancreatic ducts, and an allergic reaction to the dye. That one's just embarrassing because, well, you should have asked for it first of all, but at the same time, sometimes you don't know you have an allergy until you get one, so listen, I hate to be the bearer of bad news. They'll always ask, do you have any allergies? I looked that nurse right in the eye and I said, hey, we'll see. I have problems. Recovery. Most patients can go home within the same day as the procedure. It's recommended to avoid strenuous activity for 24 hours, so maybe just don't bend over and pick up, don't try and hit your PR to get into the 1,000 club that day. Also, don't pick up a heavy Amazon box. Drink plenty of fluids, take pain relievers as needed, follow any other instructions from your doctor. They may be recommended with patients that have symptoms like abdominal pain, jaundice, nausea and vomiting, fever, and elevated liver enzymes. What do you mean elevated liver enzymes? We haven't talked about the liver yet. Hey, give it a second, dude. Give it a second. Just one, okay? Now we're going to go and talk about more pancreatitis, okay? Because pancreatitis is not cool. In fact, I think if pancreatitis was to be just let to chillax, well, the pancreas would die because you'd be eating it, and then those digestive enzymes would explode outward, and now we have something worse. We got peritonitis. Peritonitis, guys. And if you don't remember, peritonitis is, peritonitis. Yeah, we're going to images. Disgusting, nasty, awful, painful, death. Peritonitis is not a joke. It is really dangerous and can lead to death. Yeah, it sure can. So anyway, how do we think something might be pancreatitis? Okay, well, let's start with saying you've got severe epigastric, right? Which, if we go here to this little picture, it's just for fun. It's like right here, okay? Kind of epigastric, so above the stomach. Yeah, I got my roots right. And left upper quadrant pain. So that's going to be right here, which also is where the head of the pancreas is. Wow, that's great. Or is that the tail of the pancreas? It's the tail. Okay, guys, we did fail today. We did fail today, everyone. I'm sorry. That's so funny. Anyway, so left upper quadrant pain. Worse when lying flat. Okay, now, the issue here with pancreatitis is that there is bleeding that happens because it's not like this is not a vascularized organ. All of our organs are vascularized because they have to get oxygen for cellular respiration, okay? So the issue here is that autodigestion causes damage to some blood vessels, obviously, causing bleeding. So, and this is where we're going to see some of our other signs that we might have a problem with our pancreas, okay? This is worse when lying flat, which they talked about being like a thing that has to do with blood pooling. Sorry, guys, that was really embarrassing. Why is pain worse in pancreatitis when lying flat? And I'm still on images. Come on, AI overview. Because that position puts pressure on the inflamed pancreas. Because where does the pancreas sit, guys? Right behind the stomach, right behind the duodenum, and you could even probably, right there, look at that. All of that gunk. And probably a little bit of your small intestine and large intestine too, because remember, your large intestine is like right here, chilling. Small intestine is like right here, being super like silly and long. And then here, look at that. Pancreas is being squished. Ah! Ah! That hurts so bad. Anyway, better when on the side or in the fetal position. You're going to be presenting with nausea and vomiting, because when the GI system freaks out, it says, get rid of everything. I don't want any of this. I don't want to see it. I don't want to feel it. Weight loss, because eating hurts. And I think the weight loss is going to be more of a long process. It's not like you're getting rid... I mean, unless you're nausea and vomiting like there's no tomorrow and you're in a fluid, like, volume deficit, that weight loss is probably going to take a little bit, just because eating is not going to feel good. Like, your pancreas is used to secreting stuff when you eat. Well, now it's eating itself, and whenever you eat, that eating itself just makes it feel worse. So weight loss will happen just because you don't want to eat anything, because eating hurts, as I have written here so succinctly. Okay, absent or diminished bowel sounds. Eating hurts, first of all. And when the GI system freaks out, nausea, vomiting, and it also just doesn't want to work anymore. It says, turn everything off, turn it all off, get everything out. Let's worry about working when we fixed everything. And then jaundice or icterus. Now, why can we get jaundice or icterus, you might be wondering? Well, if this pancreatitis has been caused by a blockage to our common bile duct, we are going to be having the exact same problems that blockage is going to be causing normally, which is going to be the fact that we can't get our bilirubin out no matter how much we're nausea, vomiting, diarrhea-ing, okay? Which is such a bummer, okay? Simply because now our bilirubin is finding its way into our bloodstream. Not great. So what are our labs going to... Oh, and then we have colon and Turner's sign, which I think also happen in... Don't they also happen in appendicitis? Maybe I'm wrong. Represent retroperitoneal hemorrhage that has dissected to the facial planes of the skin. To the skin. Okay. When? 2 days after onset. Okay, let me try this again. Appendicitis? Alright, well, which disease processes cause colons and Turner sign? Okay, severe acute necrotizing pancreatitis. Just pancreatitis. Most common but if there's hemorrhage in the abdomen. Dang, mortality estimate of 37%? That's kind of crazy. Yo, that sucks. Ooh. Hemorrhagic pancreatitis. So colons and Turner sign, pancreatitis. Colon sign, I kind of like to think of it because it's the circle around the belly button. And colons is kind of like a circle, like it's a C for circle. And it also kind of like, you can kind of see the C there. It's like a double C. And then Turner sign is this flank. It's like to the side. okay? Like this blood on the side of your body. You can see him right there. And it looks like this is the same guy, which is really rough. Or girl, I don't know. I'm not going to judge. And he, him, whatever. On the side here, there's Turner's side. And our professor was like, because then when you're turned on your side, then the blood pools on the side. Hey, it makes sense. Anyway, that's Colin's and Turner's signs. And if they're positive, we're worrying about retroperitoneal hemorrhage, often associated with pancreatitis. Severe acute necrotizing pancreatitis. Those are all bad words altogether. Severe, acute, necrotizing, Like, none of those words are like, okay. Anyway, so what are our labs going to look like? Our amylase is going to be elevated within the first 12 to 24 hours, and it might stay elevated for 1 to 3 days. I mean, that's if maybe it's fixed or something. Amylase. Because what's amylase? Oh, I feel like I remember seeing amylase. Okay, by the way, amylase digests carbohydrates. I think I mentioned that before. Because amy is like sugar. Carbs are sugar. Yeah. Anyway, elevated. So our amylase is going to be up. And our lipase won't be elevated for about 1 to 2 days, but then it could stay elevated for weeks. Just a fun tidbit to know. My brain is slowly starting to become necrotized. So I almost don't want to go over exactly why that is right now, because maybe I will. I actually think I'm going to need to pee here pretty soon. But let's know. Now I'm looking at the trending searches. Superman estate sues Warner Bros. Why though? All right. Okay. Why does lipase take a while to elevate in pancreatitis? Slower release from the damaged pancreatic cells and slower rate of clearance from the bloodstream. Interesting. It is so interesting. Okay. Compared to other pancreatic enzymes like amylase. So I guess it's just secreted slower and it sticks around for longer. Hey, real. Oh, and here's the thing though. That does make sense when you think about the actual function of breaking down the components of carbohydrates versus fats. The whole point of why like runners will eat like honey or like really high in like simple carb foods right before going on like a run or something is because your body can break down those carbs like real quick, really fast. And so if you needed quick energy, you could just carb your way through the day, which is cool. But as far as longer lasting energy, that's why fats if you're like looking to survive, nuts are great. Any sort of fatty food is considered, our body looks for, like, the reason that fatty foods taste so good, right, is because our body's like, that food is going to last us. That's going to last us for a long time, because not only is it higher in calorie, but it also takes a longer time for our body to eat it up, right, which means you feel full for longer, just because it takes longer for all that stuff to get broken down. All those fatty acid chains. What the frick are they called? Oh, whatever. I'm not in chemistry. I'm not going to go over it, but it makes sense when you think about how quickly our bodies are going to be digesting those two things. So that's why our amylase goes up real quick and kind of stays elevated for 1 to 3 days, and our lipase doesn't go up at all much until about 1 to 2 days. It can stick around for a longer time. Okay. We got a couple more meds here. We're almost done. I almost don't want to stop, but I actually think I will need to pee here pretty soon. That's oversharing. Other things we can look at here. is we're going to have a higher blood glucose. Oh, why is that? Because our pancreas secretes insulin. If our pancreas is auto-digesting itself, it's probably not going to be secreting the insulin that it needs to break down our sugar in the body, so we might be having a higher blood glucose, allegedly. Our liver labs, our AST and ALT may go up. I think that would more likely depend on just what kind of problem this is. If it's a blockage, that our liver might be like freaking out. White blood cells might also go up because like anytime there's inflammation in your body has, well, I feel like there's one mechanism. And the mechanism that our body can use to get rid of any sort of nastiness, any sort of inflammation, any sort of pain and suffering, it is our immune system working through our vascular pathways. So inflammation usually does just include white blood cell count going up. I don't know if it would go up as much as like, a systemic infection, but like it would likely go up. I wouldn't look at a high white blood cell count and be like, it must be sepsis. Not at least at this point. Now, I could see this rapidly turning into sepsis. What you're seeing in pancreatitis is that there's this bleeding, okay? Which includes the vascular system. In septic shock, the reason that septic shock kills people is because our blood vessels in this abdominal cavity look at this and say, we are gonna die. Everything is going badly here. There's so much inflammation. We need to divert all of our blood to this section right here. We need to divert. And so now this is great, right? Oh, I'm so glad we did that. Oh no, now our vital organs are not being perfused. So now we have double problems, especially if this pancreatitis has turned into peritonitis. I'm freaking out, peeing my pants. Also because I just drank a Dr. Pepper, so. Now this one I am going to look up because calcium and magnesium going down is just something they threw in there, and it's very important because calcium and magnesium, listen, they're electrolytes, and if there's anything I've learned from these past 3 years, it's that electrolytes are really the thing that keep our body going. One of the many things that keep our body going, but they're kind of essential for the chemical electrical processes that occur in our muscles. And at the end of the day, our muscles our heart is a big muscle. If we have electrolyte problems, we're going to be seeing that manifest all over the body. So, why do calcium and magnesium go down in pancreatitis? Look at that. In pancreatitis, calcium and magnesium levels often drop in the blood because of a process called fat necrosis. That sounds really fun. Where damaged pancreatic cells release enzymes that cause fat tissue breakdown, leading to the sequestration, which just means they're sequestered, so they're taken away and put into prison. They're on a deserted island? No. Of calcium and magnesium ions into these fatty deposits, effectively removing them from the bloodstream and causing hypocalcemia and hypomagnesemia, respectively. That's really interesting. So hold on. The pancreatitis, it's causing this fat tissue breakdown, which does make sense. I mean, you're digesting from the inside out, which is terrifying. Pancreatic cells release enzymes that cause fat tissue breakdown, leading to the sequestration of calcium and magnesium ions into these deposits. So calcium and magnesium go into the fatty deposits, effectively removing the calcium and magnesium from the bloodstream, causing hypocalcemia and hypomagnesia. That makes sense. Why, though, do they go and follow the fatty deposits? Let's keep reading. When the pancreas is inflamed, digestive enzymes like lipase leak into the surrounding tissue, causing the fat breakdown and formation of calcium soaps. What? Well. That is so interesting. What? No way. What? Release of calcium ions directly correlated with a decrease in pH value. Okay. Higher than the blah, blah, blah. Unsaturated soaps. So, when fat breakdown is released, it binds with calcium, making calcium soaps, preventing the calcium from being in the blood. That's crazy, though. Why are calcium made in the body? Can complex with free fatty acids in the gastrointestinal tracts, leading to the formation of insoluble, absorbable calcium fatty acid soaps. What? No way! That's crazy. So our body, because calcium soaps just happen. Like, they're not a bad thing in the body. The thing is, it's like, oh, we've got this extra fat. The only way we can, like, make it not become useless is to bind calcium to it. Because the calcium's like, oh, I can bind to that. Because those calcium soaps, they just, that's crazy. Proposed effect? That's crazy. Okay, anyway, and that's why calcium goes down. Okay, well, why is magnesium going down? Magnesium is also involved in cellular processes within the pancreas, and its levels can fall alongside calcium due to similar mechanisms of fat necrosis and cellular damage. So is the magnesium just like it can't just be destroyed? Like, you can't just destroy an ion. The inflamed pancreas can lead to malabsorption of nutrients. Okay, that makes sense. But magnesium plays a role in regulating calcium. Okay, but like, does it go down the same time, or ability to produce is impaired, leading to poor absorption in the intestines? Okay, natural agonist to calcium. Okay, so chronic pancreatitis associated with heavy alcohol use are particularly prone to magnesium deficiency due to combined factors like malnutrition and malabsorption. So, it's less because magnesium is going somewhere else, and it's more because calcium is going down, and also because you're not eating, you're malnourished because your pancreas isn't working, magnesium will also go down. That's so interesting. Oh, well. Huh. That's very interesting. Okay. Oh boy, now I really have to pee. Alright, well, I'm gonna be back then. It's gonna be over when it's over. When I'm done peeing, bro. Yeah, makes sense. But we'll talk about these nursing interventions first. There's so many. Fine, I'll just finish. Okay. Mild pancreatitis, which means you're not gonna die right now. NPO, yeah, they don't need anything right now. I mean, they shouldn't until they have this problem fixed. IV fluids for hydration, because, yeah, paraenteral for sure. Calcium and magnesium supplementation as indicated by labs, because yes, we don't want those going down. Pain management, of course, so PCA hydromorphone. This is a very painful process because even in mild pancreatitis, your pancreas is still digesting itself. It's not going to be feeling good. Monitoring eyes and nose and weight. Yes, of course, to make sure that, these are just going to be indicators for the fluid balance, which we don't want to get out of balance at all. Monitoring vitals. Mild pancreatitis can likely progress pretty quickly if those vitals, I'd rather catch that sooner rather than later. Medications. H2 receptor blockers or proton pump inhibitors, likely to just continue decreasing the strain of the GI system. I mean, the GI system is already going through it at this point. Yeah. I think H2, that's histamine, right? Histamine reduce some stomach acid. So just to help to, chill out the GI system just for the comfort of the patient. Anticholinergics if bowel sounds are present, just so that we can slow the progress of, slow the movement of stuff so it doesn't hurt as much. Antiemetics, they will be throwing up. Meds to decrease pancreatic enzyme production. Because the reason that our pancreas is being eaten right now is because those pancreatic enzymes, they don't just stop being produced. That is something that our bodies are meant to just make because we are supposed to be digesting and, taking care of all that stuff throughout the day. So if we can get some meds that can decrease that pancreatic enzyme production, maybe that we can stop that pancreatitis from getting worse. And then antibiotics if infection is suspected. And then from mild or moderate to severe pancreatitis, which is this plus, NPO with NG2, because this is probably going to be a much longer process, because there's a lot of other things going on here. The pancreas is connected to that duct, and if there's a big blockage there, we are looking at problems with the pancreas. We're looking at issues of internal bleeding into the abdominal cavity. We might also be looking at liver problems. IV fluids for hydration. Electrolyte imbalances, fluid deficit issues. TPN for nutrition, because their gut is not going to be let's not do anything for that gut. Oral care, if they do have an NG tube, we want to make sure that their mouth is being taken care of, not only for the reason of the patient just in their comfort, but also because they might have to be intubated because of this. They might have to be a lot of things because of this. Keeping a person's mouth clean, because it is the first thing that touches the outside world as far as our GI system is concerned. We do not want goobers. We do not need any sort of infection getting in there. Good oral care is super important. If not to just prevent infection, but also to keep that area clean and keep it healthy. Usually by eating, you secrete saliva. If you're not eating, you're not drinking through that mouth area, it can get dry and irritated. Just take care of it, Calcium, magnesium, same thing. Eyes and nose and weight, of course. Monitor vitals for signs of shock. Yes. They may develop atelectasis just because they're not going to be moving. But they're going to be sitting. They might be in a fetal position. They might be in one position all freaking day. With atelectasis, that just can simply happen because you're not getting enough chest expansion to keep those alveoli nice and round and happy. That atelectasis could go into ARDS, especially if they'd had any sort of aspiration risk before, during hospitalization, due to pain and inflammation against the diaphragm. Because, if you've got any sort of issue or any sort of inflammation down here, that's going to be making it not only uncomfortable for you when you want to move that diaphragm up into your lungs, but any expansion you do get is not likely going to be enough to want to cough and deep breathe. Let's be real. So we are worrying about all sorts of problems here and complications related to the lungs. Yep. Long-term effect, impact of gallstones or cholecystectomy, steatorrhea. What's steatorrhea? Well, steato, it commonly refers to fats. That's usually what they'll go for. Urea, I think, has to do with like a flow of something in your stools, like diarrhea. And it is condition characterized by excessive fat in stools when the body is unable to properly digest and absorb fats. So if you've had a cholecystectomy, your liver is only producing a drip of bile at a time. So if you have a really fatty meal and you don't have the gallbladder to just dump extra bile they've been saving up for that, you might just have really fatty stools that are bulky. They float because fat is pretty. It makes things. It doesn't play well with water. They might be pale or yellow. You might have some bloating and pain because your GI system can't do much with that. So not fun. And then pancreatitis, boy, digestive and blood glucose balance issues. I mean, your pancreas will probably never be the same, even if you make a full recovery, quote unquote, because it will have sustained a lot of damage. So you might be worrying about imbalances with your digestive system, so making sure, you are eating smaller, more, small little meals throughout the day, nutrient dense, but at the same time, like, nothing that would require your pancreas to, like, shoot out a ton of stuff. And then blood glucose balance issues. I mean, the reason that people have diabetes is because they have issues with their pancreas producing the right thing. And if you've had a lot of damage to your pancreas, it's like maybe limiting the amount of space that your pancreas has, or maybe even beta cells your pancreas has to produce insulin, you could be looking at issues with that in the future. And then that's the end. That's the end of the PowerPoint. Wow. What a great session. We can talk about an ERCP soon, but I don't really want to right now. So, yeehaw. We'll move on to the next one after I've had a time to pee.